It truly was an amazing effort. Great partnership with a number of different agencies and organizations, Santa Barbara Housing Authority, a number of county departments as well, public health, mental health, social services, and of course the nonprofit community and students and all the volunteers. It really was an incredible amount of work and something that we certainly needed to do. Again, I also want to just echo Rob and say that Dr. Lennon deserves all the credit in the world of this team that helped put this vulnerability index together. They did work a number of hours after seeing patients all day. Dr. Lennon is a physician in our public health system up in Santa Maria, and he's also the lead on our healthcare for the homeless grant from a medical perspective. And so they just did an incredible amount of work. Just by being homeless, I think we all recognize that an individual is going to be vulnerable. We see this every day in our clinics, in our medical system, in our hospitals, individuals coming in with illnesses or diseases that are far advanced, multiple conditions, and oftentimes so advanced and too late that you can actually do something about it. And so this vulnerability index gave us the opportunity to be more proactive, to get information from a wide range of people who are homeless throughout the county, beyond those that are just within our clinic system. The vulnerability index was based on a national model. This was done by Dr. Jim O'Connell out in Boston and their Healthcare for the Homeless program. It really is a tool for identifying and prioritizing based on risk factors for premature death. Now, it was modified slightly for Santa Barbara County. So there's an individual model that's used across the country, but we also developed a family model. We also developed a custom weighted scoring system. And so we looked at a lot of data here locally from our homeless death review report, our public health department, again, in collaboration with a number of other agencies and organizations who put this out. We looked at data from that. We looked at a tremendous amount of research as well. And we felt that we wanted to modify the scoring somewhat in some of the categories for Santa Barbara County. So as you can imagine, one clear example would be that the survey used on the East Coast puts a lot of weight on cold weather injuries. Certainly if you're in Boston or New York, that's understandable. But out here in Santa Barbara, that wouldn't necessarily be the case. And yet, there was nothing for hot weather injuries. And so, of course, if you're particularly here in San Ynez or North County, hot weather may play a key role. So we added things like that to our localized Santa Barbara version. But we still included all the same data elements and questions from the national model so that we could still have valid comparison data. And then we had the additional questions that we used here in Santa Barbara County, so we can use it both ways, comparing it to national statistics, as well as having our own data that's more specific to Santa Barbara County. And we also changed some of the scoring for age. We brought the age scoring down to age 50, and then stratified it so you could get more points if you're over 60 or over 70. Again, this was based on a lot of research, as well as our own homeless death review data. We also looked at the living situation. We added a category for veterans, the hot weather injuries, as I mentioned before, coronary artery disease and hypertensive heart disease, again, based on the research that we had. Enhanced score for HIV, particularly if it was untreated. And we also sub-prioritized by age, because that is such an important factor. So these are the primary point scoring system for the vulnerability index, although each one of these may have a different number of points assigned. So you have to be homeless for at least 6 months, plus one or more of the following markers. 3 or more hospitalizations or emergency room visits in the past year, 3 or more emergency room visits in the previous 3 months, liver disease, end-stage renal disease, which is kidney disease, HIV/AIDS, age 50 or older, history of being a veteran, history of cold weather injuries or hot weather injuries, and dual diagnosis and trimorbidity. So this is the presence of multiple categories of illnesses. For example, co-occurring psychiatric disease, substance abuse, and chronic medical conditions. I know many of you participated in the actual survey itself, and I know you can't read it necessarily, but we included this in the presentation and in your handouts. And so the first 2 pages were a lot of demographic data. And then on page 4, we got to a lot of the more detailed medical questions. As you can see, that whole bottom half, going on to the next page, really gets into a lot of detail in terms of the medical conditions and whether or not they were treated. This is a bar graph of all the different conditions and their prevalence. And I can just run through those really quickly. HIV 1%, tuberculosis 3%, end-stage renal disease 5%, cancer 6%, cold weather injury 8%, diabetes 8%, hot weather injury 12%, seizure disorder 12%, liver disease 13%, arrhythmia or irregular heartbeat 15%, hepatitis 16%, traumatic brain injury 23%, COPD, which is chronic obstructive pulmonary disease, emphysema, or asthma 25%, having a physical disability 26%, coronary artery disease, heart disease 29%, chronic pain syndrome 31%, history of reported violence 33%, and only 8% of those were reported to police, severe mental illness 35%, illicit drugs 42%, alcohol abuse 51%, any mental illness 57%, and tobacco use 59%. And again, these are self-reports, they're not a confirmed diagnosis. And we also asked, the way the questions were framed was, have you ever had these things? So they may not currently be experiencing this, but they've had history in the past. Just to highlight a few of the findings, just looking at things like hepatitis, tuberculosis, or HIV, we had a number of individuals that reported having these diseases, but very few actually reported receiving treatment at any time for them. So for hepatitis, 149 individuals reported having hepatitis B or C, and only 22 or 15% reported getting treatment for that. For tuberculosis, 28 individuals, only 13 or 45% had treatment for that. And with HIV, 9 reported having the illness, and only 3 reported receiving treatment for it. Some of the key highlights of the findings, there were high self-reported rates of mental illness and substance use, significant levels of disease burden, both chronic conditions and infectious diseases, many of which have gone untreated or inadequately treated, high levels of illnesses specific to homelessness, such as weather-related impacts and exposure to violence. The findings do correlate well with the Homeless Death Review Report, which is a report that our Public Health Department puts out annually that looks at homeless deaths in the prior year and what those causes were. Again, high levels of mental illness, substance use, cardiovascular disease. Also correlates very well with the national statistics. Just to try to quantify this in terms of economic impacts, there were 326 reports of emergency room visits and 405 hospitalizations, with an estimated cost of $3 million. And again, this is not an actual amount, this is estimated based on an estimated cost for emergency room visit or hospitalization. But again, you can see a tremendous amount of money and resources goes into this population. Some of the next steps, at least from our Public Health Department in coordination with social services and alcohol and drug and mental health. We're continuing with the vulnerability index, using it in activities such as Project Helping Neighbors. We continue with our Homeless Death Review Report. Again, data is so important to us to have quantifiable, concrete data that we can use to help target resources better. Improving coordination, communication, and care across agencies. So one of the things we found from both the Vulnerability Index and the Homeless Death Review Report was that a number of individuals would get to a nonprofit or get to one of the county departments but not be known to any of the others. And so a lot of times their care coordination wasn't very well coordinated. So we've improved identification of the homeless and we've improved our outreach efforts. We're working with the shelters, we're trying to get resources and services out to housing. We're looking at the possibility of developing a program of mobile health clinic. We have a number of partners that work with us as well, Doctors Without Walls, Center for Treatment, and of course the clinic system. Facilitating referrals and protocols for sharing of information. Of course, there's a lot of privacy issues that we have to work through in terms of sharing medical information. but we've reviewed that and we feel that we found a way to make that more effective and efficient. Collaborating to secure benefits, again, working with the county departments and some of our other partners to try to get individuals benefits like SSI so they have some source of income. Case conferences and trainings, we've been working with mental health and social services and our medical providers to enhance their understanding of homelessness and some of the things that we need to be looking out for. And then targeting resources to the most vulnerable. And so by using this vulnerability index and having a sense of which individuals are most vulnerable, we can actually go out. So for example, individuals that reported having HIV but being untreated, we actually know who they are now by name, maybe even a photo, and we can actually outreach to them and try to get them into our medical system. And there are a number of other stories about individuals who needed this type of surgery or that type of surgery or reported illnesses out in the field. We had providers or nurses going out to them. Even during the week of the point-in-time count, we did some of this. And so it was a tremendously valuable experience for our public health department, for the county, and a number of other providers. And again, truly a remarkable effort, and thank you to Dr. Lennon and to everyone who was involved. And I think that's the end of my section, and